to please be careful so that we can try to reduce distractions and background noise. I think you've all been on calls where people have put us on hold or others, and we've gotten a lot of distraction. Given the number of attendees that we expect today, I'm likely going to put all of the lines on mute. But if by any chance I do unmute everyone, please remember the basic etiquette of, don't be answering the phone. Be wary that if you're talking at the same time that you could be heard, et cetera. And if you have an option of muting your own phone, that would be really helpful. So to ask a question today, you'll see on the right-hand side of your screen, the second box down, it's a chat box. You're welcome to chat to me, the host, if you have any questions about logistics or having difficulty with the webinar itself. Alternatively, though, if you have a question for the speaker today, just go ahead and type it to all into the chat box, and that will allow others to see what the question is. We will have Dr. Shepherd pretty much do her presentation, but then we'll be summarizing and taking all the questions and answers at the end of her presentation. If the numbers and time allow, I will allow people to perhaps ask their questions in person, in which case you can right-click on the hand icon on your screen. It will raise your hand and I can call on you. That will only work, though, if you actually called into the phone after you logged into WebEx. Some of you logged into WebEx and didn't put in an attendee number, and so I can't identify you to unmute you. So today's speaker is Dr. Carolyn Shepherd. She is the Executive Vice President of Clinical Services of Clinica Family Health Services, formerly known as Clinica Campesina, for those of you who may have heard of that clinic in the past. Over the last 23 years, she's really worked to transform the clinic processes of care, including clinic-wide implementation of electronic medical record, the redesign of appointment scheduling, architectural workspace redesign, office efficiency improvements, which were centered around team care, population-based management, early childhood literacy interventions, and alternative visits for the 40,000 patients who access care from this federally qualified health center. In addition, she is leading a chronic care quality improvement partnership for a network of private practitioners in the North Denver area who serve as specialists for the community clinics that she works for. She's a frequent national speaker on clinical quality improvement and a regular presenter at the Institute for Healthcare Improvement Office Redesign Summits. She served as national co-chair for the 2010 IHI International Summit on Redesigning the Clinical Practice. She's also was a recent speaker at the California Healthcare Foundation's Patient Experience Conference in January of this year, and it's partly in response to the wonderful feedback that we got about her talk that we've asked her to provide this webinar today. So I am going to actually hand this ball over to Dr. Shepherd and allow her to take over the slides and tell us a little bit more about her work. Dr. Shepherd.
All right, Sophia, thank you.
Can you click it? Yes.
There you go. Now I got it. All right. Thank you very much. I'm going to just get started telling this story, and we'll try to be sure and leave time at the end for people's questions. Clinica is a 35-year-old FQHC, and we have 4 clinical sites. Let's see, let me get this set up. There we go. Last year we did somewhere between 170 and 180,000 visits for low-income patients in the North Metro Denver area. These are our vital statistics. I'm sure most of the people on the call have similar populations that they're serving. We currently have almost 380 staff. We have 49 full-time equivalents of provider time, but we have a lot of part-time providers, so that's about 67 providers total. We have integrated clinical pharmacy services, behavioral health, and dental. We follow our patients in 2 community hospitals, and we have a large OB practice. We deliver about 2,000 women a year. I have 2 slides about our journey to the point we're at. And I'd just like to remind people that we've been on this path for a long time. In 1998, we joined the first IHI HRSA pilot collaborative with 4 other community health centers and a half a dozen private integrated multi-specialty clinics to work with Ed Wagner on improving chronic illness care for patients with diabetes. It became obvious to us that our systems were just significant barriers to activating the patients and delivering all and only indicated care. And so in 2000, we began by working to fix our patient access problems. Wait times for our preventative health care visits at that time in 2000 were about 5 to 6 weeks long. We needed to fix our provider-centric inefficiencies also by figuring out how to build high-functioning care teams. And we realized that we had to offer other models of care for our patients besides just the one-on-one visit. So at that time, we called them the Big 3. Since 2000, we've been spreading lessons learned to other chronic diseases and preventative health and trying to redefine and redesign our processes. Over the last 5 years, our ability to improve our systems has really increased, and we have tried to sharpen our focus on behavioral health integration by adding difficult to manage populations of patients, such as patients with chronic pain, patients on warfarin, patients with ADHD, and patients who have severe and persistent mental illness. So we have registries and population-based management for all these groups. I think it's important to stress that the availability of data from an electronic health record coupled with being able to find sophisticated and tested change packages really make it much easier now to shorten the time it takes to cycle through iterative PDSA cycles to create really meaningful improvements. Looking back, we have changed a lot of things at Clinica. However, most of us agree that these 6, which we call the Big 6, have helped the most. And I'm going to spend the rest of my talk on these 6. Number 1 is continuity, and it's number 1 because it makes gains in every other dimension easier. Continuity is the most patient-centered focus area we have. We assign every patient to a primary care provider and clinical team. We have done a lot of work around color branding to help patients understand that they have a care team. We have appointment cards, provider business cards, charts in the old days, and even our physical space is color branded. We found these sorts of strategies really help the patient know which team they're on. Patients also told us it's important to them to see the same front desk people and check in with the same MA and know the nurse and the behavioral health professional. So we really work on reporting continuity outcomes every 3 months, and we report and manage unassigned patients, patients who don't have a PCP. We work that every month. The dark blue line on this run chart is the percent of patients receiving well-child checks who were seen on their team, and the light blue line is the percent of patients who were seen by their PCP. Now this graph is old, 2003 to 2009. In the past, we had been using well-child checks as the sample for looking how we were doing with continuity for preventative care. We use diabetes as a sample for continuity of care for chronic disease, and asthma patients for a way to sample how we were doing with acute care. With our EHR now and our data in a data warehouse, we can look, though, now at every single patient. The lesson we learned here is there will be a need for some reanalysis and improvement when we use our EHR to study more than just sample populations of data with the business intelligence tools. We found that we had been improving outcomes, but not necessarily across the board and not necessarily to the extent that we had seen with sampling. Here, when we looked at 100% of patient visits, so not just those three groups, billing, provider, and assigned PCP showed us that only 50% of the visits at our PECOS clinic were actually with the PCP. When we had looked at them using our sample populations, they looked as good as our other sites did. You can see a patient, the pink line, back in September had only a 50-50 chance of seeing their PCP. This is a pattern that we've seen many times. Our immunization rates, time to third next appointment, PAP rates, where our outcomes based on whole population actually show us more room for improvement. And I'm just bringing it up because I think it's a good thing to be prepared to manage. There'll be disappointment about that. And it just means that it's a new level of meaningful use of the data that we can now get because we have access to data from EHRs. The second most important issue for us to improve chronic illness care is access to care. We have had 10 years experience working on this, and we are much better than we were when we had 6 weeks to the next appointment. But we still have periods of time when access for the organization is not perfect. Our experience tells us that this work is never going to end, that this is a strategy, not just a project. There will be periods when you're trying to do improved access when providers are out on FMLA or on vacation or we have vacancies. And during those times, waits recur. I want to make the point that it's important not to give up on advanced access. It's essential to remember that when you see a spike in August, like on this graph in 2009, it's because providers need vacations and kids need back-to-school physicals, and we can try to work on that over time. The next peak on our time to third in 2009 happened to be because Thanksgiving occurred at the same time the swine flu came around, which was early, right? And so we saw another peak where our time to third next appointment went back up to 6 days. But we can continue to work it down and still provide improved access to our patients. As I mentioned earlier, we continue to aggressively work our panel reports, reassigning patients when providers leave, hiring new providers early when you know you're going to have turnover, balancing risk-adjusted panels will all help improve both continuity and access for your patients. Our goal is to have no more than 4% of our patients unassigned at any one time, and really for the past 5 years, I think we have never gotten over 1%. In last year's quarter panel report that you're looking at, you can see in the first highlighted yellow line there are 6 patients who remain assigned to a provider who retired in August. What that means is somebody worked to move his other 700 patients to other PCPs. And so already by the last quarter report, we could see that almost all those patients had been reassigned. In the second yellow line, there were another 23 patients who were not assigned a patient, and we find most of these patients are new patients to us in the clinic, but we've seen them covering the emergency room in the hospital or something like that, and so they get in our system, but they don't come through the usual way. Our operations staff will fix the defect of these 23 patients as they work this report monthly. What's most important is managing the time to third, provider by provider, and patient by patient. Here, this provider, Amy, has same-day access on 45 of 52 weeks. So 87% of the time, her patients can call in. and get in on the same day. Yes, she took a vacation in February. She's going to take some CME leave and some other vacation in other parts of the year, and the best we can do is manage those patients will only see one or two other providers on her pod or team, not one of 60 in our organization. So when I have helped other health centers with this, I think the most important thing is don't give up on advanced access. And try to remember how bad it really was before you started. So, because 6 days seems horrible to us, and we all feel bad about it, but it used to be 6 weeks. Another key concept for improving access is around management of demand. We all think about managing supply, meaning the providers and the time they have available, but at Clinica we do have some control over this, and we're getting better and better at sculpting demand itself. Winter is our busiest time, and for 2 decades we had talked about the summer slump. So we always have less patients who want to come in the summer. On this graph, if you focus on the blue bars, you can see in the months of April through September, there is a decrease in visits per day in 2009. And this is our recurrent summer slump. If you looked over the last 10 years, we have this phenomena every year. Last year, we decided to try to aggressively outreach and in-reach to have our prevention visits, PAP, mammos, well child checks that are on a yearly schedule during the summer months. The maroon bars show in 2010 we were able to essentially eliminate the summer slump by having 4- and 5-year-olds come for school physicals in April and May, and along with other prevention appointments. We also don't bring stable chronic disease patients, folks with asthma, COPD, diabetes in during the flu season. If a patient is due for every 3-month diabetes check at the end of February and they're in fairly good control, we will reschedule that and make it a 4-month interval and not bring them in until the end of March in order to help sculpt demand and to leave supply available for our patients who need it, who have acute URI and flu. The next of the big 6 is team-based, or we originally called it office efficiency or team-based care. I believe we are failing in the country to provide indicated care because we have had 50-plus years of a physician-centric system. When the patient is with me, I feel like they want to talk about the stress they have because they can't sleep, because their Uncle Eddie is in jail, and now they don't have a ride to get to work, and that's why they didn't get their insulin this month. It's not the time I will remember, or even if I do, I can't, and maybe shouldn't, put getting a fasting lipid panel at the top of the patient's agenda. Strong teams can help us do all algorithm-based care, and frankly, I think they do it better. They certainly do it better for us at Clinica. This is a picture of a red pod team huddle with the nurse in stripes talking about care with the front desk. The MAs attend the huddle, the provider, our behavioral health professional. These huddles really facilitate handoffs of work that allow everyone to work at the top of their license. In addition, you can tell this is Red Pod. This is our Red Pod at Pecos, and you can tell that we've redesigned our physical spaces in order to optimize staff working together in a team. Now, that said, it's you just can't wave a wand to try and get everybody to act like a team. We are explicit about what the roles are for each member and who is responsible for each piece of work in an important flow diagram or process diagram. This is what we call a workflow that you're looking at. It's not intuitive, and to effectively shift work from the bottleneck, which is almost always the provider, we start with flow diagrams, but then we turn them into this that you're looking at, which we call a workflow, which tells team members what needs to be done, when, and by whom. And this is the diabetes workflow, and there's just a ton on this slide, but what I want you to do is just look at the yellow column on the left-hand side. You can see that the operations is responsible to print the registry. The front desk has a big box, a big yellow box, because they have a lot of tasks, as does the case manager. And just notice how small the row is for the provider. This is all algorithm-based care and can and should be done by other team members, freeing up providers to partner with patients on addressing their barriers to their better health. We have workflows for all our major registries and other important processes that we do in the clinic. This is one of our super sharp front desk people who work the registry for us based on the algorithm. And in between checking in patients, and particularly late in the day, she has in front of her, you see a white paper registry that gets printed out of our system, and I can talk about why it's paper later if you're interested. And she also has a laminated yellow ruler that has instructions for deciding who needs appointments, who is it time for them to get a referral for eye care, the other interventions we do. On this next slide, we'll look at exactly what she's looking at when she does this work at her front desk. So this is an example of a registry that we use for our patients with diabetes, and we pull all these data points directly out of our EHR to populate the registry. The yellow laminated ruler is just a tool that our front desk staff use to decide what action to take when working the registry. When you look at the last visit on the registry, the ruler says that if it has been more than 6 months, this patient needs to come to clinic for an appointment. No other decision needs to be made. It's time for that patient to come in. And as you move to the right on the ruler, more decision steps are defined for our team members. It's just tools like these, I think, that empower our staff to apply population-based care for us. And by translating the very same algorithms we've memorized as providers in our heads, we can have our staff help us order the care that patients need so they get all and only the indicated care at timely intervals. This is another example of having teams help us out. We have increased our documentation of the meaningful use measure to document counseling to patients who use tobacco to quit. Our medical assistants have added a piece of work to their process where they ask at every visit if the patient uses tobacco. And then they add tobacco abuse to the reason for visit and open a tobacco template for the providers and save that. So these two actions make it really hard for the provider not to document that the patient was counseled to quit smoking. It's the medical assistants who have actually made this measurement improvement for us. I included this slide because people always ask who is on our team, and we have designed our teams, we call them pods, to supply the services that patients need when they come to Clinica. Services that they might need at other times, but not at the time of the visit, such as billing services, are not located on the pod. Before remodeling our facilities, our structures, our architecture had emphasized isolating team members rather than improving communication, facilitating handoffs and working at the top of your license. The majority of our patients like one-on-one visits, but the fourth item of the Big Six is improving the care model or the experience of care that patients have. We know that some care is better provided in group settings. More questions are asked. Patients are better engaged, and their confidence and abilities to manage their care increases. We added group visits in 1999 because we knew that about 40% of our diabetics were not doing well with their diabetes, despite the fact that they were being seen regularly by their PCPs. Believing that the right label is not non-compliant, but rather not yet engaged, encouraged us to think about offering other models of care to patients. We started with group care, and we are continuing to look at other kinds of care, such as e-care, where we've been rolling out a patient portal, and telephone care to those for whom one-on-one visits and groups don't meet their needs. So it's not like we think there's only two right answers. I'm sure there's lots of other ways to deliver care effectively. This picture is a group of 2-year-olds getting their reach out and read books. This group actually has 8 kids in it, but the picture was taken with a cell phone camera, sneaking in there when they weren't looking. And there are 8 kids here who all have been together since they were in utero. Their mothers attended a centering pregnancy group with their PCP, and then the PCP and that group of mothers, along with their babies, then attend centering parenting groups for the kids from their newborn check to their 2-year-old well-child check. The dynamics in well-facilitated groups can be startling and I think even transformational. Patients are engaged, they help one another, and they're very effective at holding the line when folks make excuses for why they can't meet goals to better manage their health problems. I have a little bit of data just to support groups. This chart shows a few of the outcomes. These are centering patients. 2009 is the last year that we have both national and state data, so we compared it with those data points. The national C-section rate, embarrassingly, in 2009 was over 30%. At Clinica, our C-section rate is 19%. In Colorado, our C-section rate is around 25%, and at Clinica it's 19%. And women who are in our centering pregnancy groups, our C-section rate is 17%. You can see our low birth weight rates and our preterm deliveries, which are probably even more important, are also lower in these groups. Groups also increase access and productivity, I believe, is a happy accident of this model, but not the reason we do them. Group visits are hard work. We do them because the outcomes are better. When we have unbooked slots, we don't take patients out of group and put them back in to single one-on-one visits because we believe the care is better when they're with their peers. This picture here is of a team group, one of the team groups we do. Teams come for 4 once-a-week evening group visits with their mothers and occasionally their fathers and get their HPV vaccines. We do these at night so their family can come and we talk about what is important to them. Here the parents, the case manager, and the PCP are all talking about some core content that I'll explain in the next slide. For all of our group visit types, People always ask us how we manage the education provided in a facilitated group setting where the patients lead on what they want to discuss. We call these the core content thread diagrams, and we do one for every kind of group visit we do. We know sometime during the group it's important for us to cover all of these topics. And before a group starts, the team and the PCP review the core content threads which have been covered for that particular group and those that still need to be addressed. This is the role of the PCP to facilitate the discussion and work in the content threads where they're appropriate. For example, in the teen HBV groups, in the last fall, patients really wanted to talk about anti-immigration issues. The PCP then brought in family relationships by talking about how they were going to communicate with each other if something happened to someone in their family. And we have the teens talk about why these relationships were important to them. So you can work the content threads in by developing them around what the teens are interested in talking about. And it's the same for our other group visits. Number 5 is information technology, and this has been a key initiative that has kind of helped supercharge or super speed up our work on improving patient experience. The idea isn't to move from a paper chart to an EHR just so you have an electronic chart. For those of you implementing EHR, I know this is really disappointing, but it's only the pre-work. I think the question is how are we going to then meaningfully use the information from that EHR data. When we started redesigning in 1998 until 2006, we had only paper, but having robust EHRs that are populated with our patient data really helped drive the speed of our study phase of our PDSA cycles and dramatically have increased our ability to successfully implement change. Displaying data over time is critical. I say, don't show me a fancy dashboard. Give me a line that I can understand that shows how I'm doing over time. In this case, lower average A1C is better. The dark blue line is Clinica's average A1C for our 2,000 patients with diabetes. The pink line is the average for the Pecos Clinic. The red pod at Pecos, which has 3 providers, is the yellow line. And we generally post most of our outcomes at the pod or team level because we think it's the pod or team that can really improve them. This data gives the supervising physician and the red pod nurse and the provider something to sit down and look at because the problem is pretty clear. The single red pod provider, whose name isn't there, is the turquoise line. And it turns out that this is a real conscientious provider who was intercepting his his registry to do, or actually not to get around to, the work himself. And starting in January, he agreed to hand off the work of managing the registry to the team. And what you see here is initially a rise in A1C because we started bringing in more of his patients, followed by a steady improvement. I think this is the meaningful data which helps us have important conversations around the need for change and then to follow the results of the PDSAs for successful improvement. Although we have 7 robust registries for chronic disease, we have been all along on a journey to find what we call the ultimate registry. The person who works on this in IT calls it the mother of all registries. We want a single patient-centered registry rather than a disease-centered registry for our important chronic disease populations. This registry would show care and prevention interventions that are due now or in the near-term future, so we can make single outreach calls to patients, and so we can maximize what we do for the patient when they do find time to come in and see us. What you're looking at here is the depression registry, which is the first example of this functionality we're building for a single registry. If something is due now on this depression registry, like a 2-week phone call or a follow-up PHQ at a year, then the patient appears on the registry. If there are no alerts, we call them, or items due, then they don't display on the registry. So now, instead of that front desk person having 6 rulers and 6 registries, they'll have 1. And because of the power of significant business intelligence logic, we can take all those rulers and embed the logic into the report so that what shows for the front desk and the case manager is the things that need to be done today. That was impossible until we converted to electronic health records, had enough data in there, and then really understood how to make the code of the registry work for us. The last area, and I certainly think it's the most important, is finding ways to improve patient engagement. And once we've removed the most significant barriers to patients, such as lack of continuity and poor access, we became much more effective and freed up really to address improving patient activation. Telling patients to come back for a follow-up in 2 weeks when the next available appointment is 6 weeks out only deactivates patients. In our centering pregnancy group visits, we have moms take their own blood pressure and dip their own urine, record them in a shadow paper chart. Then they show these results to the medical assistants who enter them in our EHR. We do this not because we want to have paper charts, but patients really know what their last blood pressure is. And if this woman goes to labor and delivery, she can tell the hospital staff that she never had protein in her urine before. So building a relationship and teaching skills which facilitate patient engagement and confidence really is the widget that we're trying to make here at Clinica, and I think what we should be making in healthcare in general. We try to stay on message and emphasize the patient's roles all the time. We say to patients, your diabetes or your ADHD or your hypertension or whatever, your abnormal PAP is a serious condition. There are things you can do to live better with diabetes and things our team can do to assist you. We, the healthcare team, not the doctor, we, the healthcare team, are going to work together on this. And we try to build that message in wherever we can. This is another example of a tool we use just to do that. Our patients in our anticoagulation groups actually fill out and keep the chart of their INR values over time. It is really helpful for them. They know what their INR value is. If they're seen in another setting in the ER, they can say my INR was 2.6 last Friday. This is important tools for the patients. Trying to improve patient activation means that we have to get better at behavioral health interventions, and we need to design decision support for interventions that are known to work for patients in motivation. So motivational interviewing, patient perceived self-efficacy, all those strategies help facilitate patient engagement. And in our health centers, we have to find ways to make those happen, just like we find ways to make immunizations happen. This is our tobacco template. I talked about it a little bit earlier, and we built it on the 5 A's model. not because it's the only way to do tobacco counseling, but we wanted to have these models sprinkled through our EHR so that staff, all staff, including providers, are more competent at using these tools. So it just takes seconds to document in this tobacco template that you've advised a smoking patient to quit and that you reviewed the effects of secondhand smoke. It's really 3 clicks as long as the medical assistant has opened the template for us. The template also then has decision support if a patient is ready to move forward. It reminds to assess their readiness to quit, and you fill in a drop-down there that says they're contemplative or whatever level they're at, and that they need arrange some follow-up so that we can build the 5 A's in right on the template. This notion of patient perceived self-efficacy, or their ability to actually manage their life around either disease or what's happening to them, is really important. And it's imperative in this picture that this young father recognizes the importance of meeting his new daughter's needs, and that he is confident that he knows what to do for her, and he's confident that he knows exactly how to get the help he needs when he is unsure what to do for her. I'm going to say this again because I think it's important for patient experience. Confidence is the widget that we need to make. This is the opportunity we have to significantly improve the health of the families that come to Clinica. We ask patients all the time, how confident are you that you know what you need to know to be able to care for your daughter, that you know what you need to know to manage your diabetes, to manage your blood thinner. Like everything else, we won't know how we're doing unless we have a way to measure it, and we use the scale from the Stanford model of chronic disease self-management. So just to wrap up here, a couple lessons learned. Put the patient first by starting with continuity. Optimize the team. Hand off as many evidence-based algorithms as you can. Keep looking for ways to add the patient's voice. Let them choose the content thread. Get patients on improvement teams. We scan and share comments that patients have given us, good and bad. We have actually had some luck with videotaping patients telling their stories in their homes with their families present. We show those at provider meetings and staff meetings. It gives the patient a powerful voice that we might not otherwise hear. I think just getting started is important. Don't be paralyzed. Each improvement that we make has led us to the next logical problem. The higher the resistance to an idea or a concept, the smaller the PDSA cycle we do. We use the QI tools that work. I'm not smart enough to have developed any of these tools, but I am smart enough to use them over and over again. And then we measure data over time. Then just finally, I just comment on where we're looking at going over the next 5 years. Just kind of what we're thinking about is we're still going to work on the big 6. We still have lots of room for improvement. We want to be experts in patient activation. We want to use patient-centered tools like a single registry. We're adding the patient portal and participating as the pilot site for the statewide health information exchange, and we're dabbling in community accountability through our ACOs. So, Sophia, that's my last slide, and we can try to do some of the questions if you like.
Thank you so much, Carolyn. That was like so full of information. It's great. So I've got a couple questions already, and I'm going to encourage others who want to ask additional questions to go ahead and put them in that chat box and send it to all participants. So the first couple questions, Carolyn, were about what specific EMR actually are you using, and tell us a little bit more about that registry tool.
Well, let's see. We use NextGen. We started with that 5 years ago, and the intrinsic reporting capabilities of all of the EHR applications that are out there right now, I think, are woefully inadequate. They're all getting better, but we then decided we needed a strategy to pull our data out of the EHRs. EHRs are what are called transactional databases, so they're really great at remembering what day you saw what patient and what was done, but they're not very good at comparing the data, or a relational database, which then gives you the ability to really analyze the data better. So we use Microsoft reporting services. We every night take our new data and put it in our business intelligence tool, and then had the technical capability to develop very sophisticated registries.
And so that's mostly in-house then?
Yeah, we do this all in-house, but we share our reports. We're in a shared EMR, and we share our reports with our private practice partners and the IPA that we're a member of. And so a lot of people are working and thinking on how we can make the data better. So we get a lot of additional comments from other practices, but in-house we do the work.
Great. So a couple questions about data. I'm going to make this a two-parter. One is kind of how is it that you are able to gain the widespread support amongst your clinic team in terms of how they use the data to understand what to change? And then the second part was how do you collect specifically the data to measure demand?
Yeah, we for the first part of the question, we have been looking at EHR outcomes and data now really aggressively for about 4 years. But prior to that, we were also looking at data that was hand-collected laboriously by weary people in dark closets. So I think we had a culture for quite some time about using our data to look and see where we can improve. And to be honest, I don't dream up any projects. We have way more suggestions from our teams about what's not working for them, and we would do 10 times as many PDSAs if we did all of them. My job really is to filter out the ones that I think have the biggest bang for the buck so that we can share it across all of our sites. So we have a culture where teams know there's a problem. Maybe they have an increased cycle time, and they want to understand their cycle time because their cycle time is worse than any other pod in our organization. That team comes to us and says, we want this data, and we want to have this, and we want to be able to study this in a PDSA. So it really comes from the team. I think the job I have is to look at our community and identify which are the problems that we can best address using population-based medicine. We cannot do every single possible diagnosis in a population-based management approach. We have to look at what's common for us, what we spend a lot of money on, and what we don't do very well. And I know that there are scleroderma patients out there, but I'm not going to have a scleroderma registry. I'm going to look at hypertension, obesity, diabetes, anticoagulation. So that was the first question. My job is sort of to narrow it down, not expand it out. I hope that answered the question about motivating the teams. It really comes from the teams. And I think it's because we've been successful at fixing problems for them. So people see this as a successful tool.
And Carolyn, I think I'd add that part of it is that you give them their own data as well.
Yes. Yeah.
So they have to kind of own it and embrace it.
Yes. Yeah. Yeah. And there's nothing like we have 13 pods, and there's nothing like being pod number 13. on a report. People are just interested in figuring out how to do a better job. It's not necessarily competition, but it's benchmarking.
Mm-hmm.
And then tell me what the other question was.
The second part was then how do you collect data to measure demand? Was it around calls for appointments? This is going back to some of your early kind of access work.
Yeah. We have always used time to third. So originally somebody called on Wednesdays, went in, looked in the schedule to see manually what count out the third next available appointment. We then were able to do that. We do that electronically in our schedule now. So we have a crystal report that we have written that allows us to do that counting in quotes. Early on we didn't include weekends, so if the third next available appointment was on Monday, we wouldn't count Saturday and Sunday. Now we do it all from the patient's perspective. So if the patient calls on a Wednesday, and we do it in the afternoon because we have capacity in the morning and we want to really see what's out in the future. So a lot of our slots are open in the mornings when patients call in, and so we don't want to count time to third right at the start of the day. So we let it kind of fill up and we count right after lunch on Wednesdays. I think there are better measures, but this is a measure that has worked for us, looking at your percent of future slots that are open. It's something we're looking about switching over to. The problem is now we've got 10 years of data watching our time to third, so we know a lot about that indicator, but I think there probably are a few better ways. And I do know that other people are saying measuring access should be all a patient report. We should do focus groups and ask patients, did they get the appointments they want? So I know there's people who are thinking we should move away from these metrics, but we hang in there with them because it tells us when we're getting into trouble.
Great. A couple other kind of questions. This is, again, from some of the early stuff that you presented. One was a specific question about that slide that you showed where you improved the percent continuity for the PICOS clinic starting in January 2001. One of the listeners just wanted to get a better sense of what is it that you actually did to make that improvement?
They actually had a lot of PDSAs around this. They went back and for, several months, revisited and rehanded out cards to patients. So we decided we needed to be sure patients knew that we thought it was important that they see their PCP and that they would be able to. And so we gave them the provider cards out again and encouraged patients to help us in our attempt to improve this. And they re-educated sounds a little austere, but revisited the issue of continuity with the people who schedule appointments, so people who answer the phone calls, the MAs who schedule patients back in for follow-ups, nurses. We did presentations at the sites about what are the reasons that it's okay to schedule it with anybody besides the PCP. And we wrote scripts for staff that would say, Dr. Russell really likes to do the well exam for the women in her panel, so she will be here on Wednesday. Can you come on Wednesday instead of today? So we had stopped asking patients that. We just gave patients today's appointments. So there's this sort of tension between access and continuity, and you have to be good about understanding when continuity trumps access. I would say for well woman exams, that's a good example. And if we can talk her into coming either next Tuesday or Friday, that's better, even if we have an appointment today with someone else.
Okay, a couple more questions here, and then I think we're going to be out of time. One was, again, relevant to one of your other early slides, which was showing about a new PCP for a patient, and the very specific question was, how do you assign a patient to a new PCP? Is an appointment required, or are they just assigned?
Yeah, so once a month we run a report of unassigned patients, and we work that, and so some of those are new patients to us. We've seen them in the hospital, but they haven't come to the clinic yet. But for new patients who come into the clinic, we know whose panel is full and whose panel is full of chronic disease but might still be open. So if we have a 26-year-old woman with no medical problems, when patients come for their financial screening, we let the financial screener know which practices are open to that kind of patient. So they assign it to the physician on the red pod to see that patient or the nurse practitioner, and that becomes their PCP. And if there are people who have a disproportionate share, they've been here longer, they see more chronic disease patients, so that increases the demand for appointment time for them, then we will direct patients, if they still have room in their panel, who are not in that. We use age and sex as a indicator for morbidity, who's going to need the most appointments. Then we might assign a 36-year-old male into somebody whose panel is full with chronic disease patients. So our clinic operations folks know what kind of people we're looking for, and then we just slot those new patients in.
Great. All right. One last kind of a little bit more of a nitty-gritty question, I think, not as specific. One of the listeners would like to just get a better sense of who actually runs these reports, and how is it that you are engaging? So you mentioned you've got numerous sites, you've got numerous pods. How does that operationalize? Who actually leads the improvements, runs those PDSAs? Can you speak to that a little bit?
Yeah, we a bunch of different people is the answer, but let me if I can make this clear.
Try to generalize, maybe.
Yeah, that doesn't probably help too much. So for things like running reports, if they're standard reports, we put them on what we call institutional memory, which is nothing but essentially an Access spreadsheet, and remind people. We get little reminders. Run the flu card list on August 1, and that comes out to a job description. That person runs a report, and then we have a series of steps, also very explicit on who does what to get the cards out on time so we don't forget or do it late or lump them all together at the end. If we're doing PDSAs, the team will decide maybe they want to do a PDSA on improving continuity. Let's use that example. Then the clinic manager, the operations folks, take the lead on being sure we have what we need. And we have a very robust PDSA database, so no matter what site you're at, you can go in and look at all the PDSAs that have been done about continuity and what the outcomes were, so you don't have to start completely over. You fill out and design with the team. They sit in a huddle or they sit in a management meeting and say, here's what we want to do. Here's our PDSA, and here's the data points we need. And sometimes there are data points we can get simply for them by running very simple crystal reports for them. Sometimes they're very complicated data reports, and those have to go through our report developer and our business intelligence tool. And those just have a longer timeline to get that data out. But if we're going to ask for those reports, then the clinic director and the clinic medical director will both go through and together try to design those PDSAs.
Great, thank you. And it is the end of the hour here, and so I am going to let folks go. I put up the slide to show folks where the URL will be, where the recording and the presentation from today will be posted. And Carolyn, I just have to thank you for an absolutely wonderful presentation, and thank you everyone for listening in.
Thanks, Sophia.
Take care.
Bye.
Bye-bye.